all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is Professor Dr. Philippe Moreau from France, and he's going to lecture us on newly diagnosed multiple myeloma, individualized therapy. This webinar is brought to you by Mumbai Hematology Group, supported by Jensen, Nirvin Life Sciences, and managed by Perfect Square. I thank Dr. Utya Deb, Mr. Hitesh Khandelwal and Team Jensen, Mr. Paresh Prabhu and Team Nirvin, Mr. Yash, Mr. Kalpesh and the Team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Ashutosh Panigrahi, our guest speaker for the day, Dr. Philippe Moreau from France, all our discussants who are themselves very eminent hematologists and hemato-oncologists, and you participants for sparing the Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 20th of April 2024, from 7 p.m. Indian Standard Time onwards, we have Dr. Ryan D. Casade from Seattle, Washington, USA, speaking to us on CAR T-cell therapy for adult ALL, where we are in 2024. And following day, that is Sunday, 21st of April 2024, from 11:30 a.m. Indian Standard Time onwards and 7 a.m. UK time, we have Dr. Shankara Panisha from Birmingham, UK, speaking to us on treatment landscape of CLL in 2024. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Abhinit Deshmukh from Sahyadri Hospitals, Pune, Dr. Akshay Mandloy from Agilus Diagnostics Mumbai Reference Lab, Mumbai, Dr. Amber Garg from DKS Hospital, Raipur, Dr. Akanksha Garg from Zydus Hospitals and Zydus Cancer Center, Ahmedabad, Dr. Ami Patel from Blood and Cancer Institute, Surat, Dr. Bausaheb Bagal from Tata Memorial Center, Mumbai, Dr. Bhavani Mandava from IMS and Some Hospital, Bhubaneswar, Dr. Chandrasekhar Bendi from Mahatma Gandhi Cancer Hospital and Research Institute, Vizag, Dr. Digambar Panchal from Sahyadri Super Speciality Hospitals, Pune, Dr. Dinesh Ranasinghe from Cardiff, UK, Dr. Dinesh Sheth from Mangalore Institute of Oncology, Mangaluru, Dr. Hasmukh Balar from Blood and Cancer Institute, Surat, Dr. Kumar Animesh from BLK Max Super Speciality Hospital, Delhi, Dr. Kunal Goyal from ACTRAC, Mumbai, Colonel Dr. Kundan Mishra from Command Hospital, Lucknow, Dr. Meena Verma from BLK Max Hospital, Delhi, Dr. Mitesh Halwawala from Surat, Dr. Mukesh Sharma from NHMMI Narayan Health, Raipur, Colonel Dr. P. Suresh from RNR Army Hospital, Delhi, Dr. Pawan Kumar Singh from BLK Max Super Speciality Hospital, New Delhi, Dr. Ram Prahlad M. from Jamcare Hospital, Hyderabad, Dr. Steve Thomas from Sri Ramachandra Medical College, Porur, Dr. Sushil Selvarajan from Christian Medical College, Vellore, Dr. Tribikaram Panda from Artemis Hospital, Gurgaon, Dr. Yimon Tan from North Okalapa General and Teaching Hospital, Myanmar. Now it's the time to introduce our guest speaker for the day. We have with us Professor Dr. Philippe Moreau from France. Professor Dr. Philippe Moreau is Director of Cyric Iliad, Professor and Head at the Department of Hematology, University Hospitals of Nantes, France. He is also the head of the Translational Research Program in Hematology and Oncology at the University of Nantes, France. He has over 20 years experience in clinical hematology and has led many pivotal clinical studies. His interests are focused on multiple myeloma and his treatment with high-dose therapy and novel agents, including cell therapies. He has been the chairman of the Intergroup Francophone du Myeloma, that is IFM, since 2020 and vice president of the International Myeloma Society, IMS, since 2019. He has been a member of the steering committee of the International Myeloma Working Group since 2013. He has served as the principal investigator for many international randomized phase 3 clinical trials evaluating proteasome inhibitors, immunomodulatory drugs, or CD38 antibodies. He participated in the study of idacaptagene viclucil that received FDA approval in March 2021 as the first genetically modified autologous CAR cell therapy for the treatment of relapsed refractory myeloma. In 2018, he also received the Robert A. Kyle Lifetime Achievement Award. He is a member of the integrative oncogenomics of the pathogenesis and progression of multiple myeloma team of C.R. Sina, directed by Stephen Minwell. He is very frequently invited speaker at international hematologic oncologic meetings. He has authored as well as co-authored more than 400 peer-reviewed articles that have appeared in high impact factor journals, including NEJM, JCO, Lancet Oncology, and Blood. He is a member editorial board of JCO, Blood and Blood Cancer Journal. Today, he is with us and is going to lecture us on newly diagnosed multiple myeloma, the individualized therapy. But before we do that, we have our chief guest today. And we have the chief guest is very near and dear to me, my friend, Dr. Ashutosh Panigrahi. Dr. Ashutosh Panigrahi is additional professor at Department of Medical Oncology and Hematology at AIIMS, Bhubaneswar. He is a state member, National Cancer Grid, core group member for Blood Disorders Rehabilitation Scheme of India, state trainer for hemoglobinopathy control program in Odisha, life member of ISHBT, IAP, and IMA. His areas of special interest include sickle cell disease and plasma cell disorder. He has publications in numerous national and international journals as well as book chapters. It's my privilege to welcome Dr. Ashutosh Panigrahi to inaugurate our webinar and give some words of wisdom. Well, thank you so much. Over to you, Dr. Ashutosh Panigrahi.
Am I audible?
Yes, you are audible.
Yes. Okay. Good morning and happy Indian New Year, because it is being celebrated in different parts of India now for this month. And good morning to all the audience. Thank you, Professor Agarwal, for your invitation to be the chief guest. And also thanks, Dr. Amit, for your kind introduction. I'm really happy to address the august audience from India and abroad, and to inaugurate the CME with words of wisdom for youngsters who are interested in the field of hematology. Hematology is interesting and charming, no doubt about it. Do you feel excited when you treat a ITP or APLA patient, you diagnose the patient, treat the patient, give a baby in her lap, and guide them to have a good family life? Isn't it exciting? So it is one of the examples. There are so many examples where you will feel thrilled to be a hematologist. To choose hematology as your career, you should have the passion and thrill from within, without which you cannot prosper in this field. Hematologists always deal with critical cases where critical decisions has to be taken at the time point. So for that reason, if you choose hematology as your career, you should have some qualities. First and foremost is you should have the competence and expertise in this field. You should have the ability to work as a team leader or work as a team. That is very important in our field. And you should have a good communication skill with patients, with relatives, with your colleagues and your teachers. You should also have a good behavior, also ability to speak in forums in clear sentences. After you get your degree as a trainee, now there are vast opportunities where you can practice and earn. Only broaden your mind, that's it. You can adjust anywhere, you can work and enjoy your subject. Do not forget that in this field, once you are passed from this residency, you will remain as a student throughout your life. In this regard, I can tell a Sanskrit slok that tells Vidya dadati vinayam, vinayat yati patratam, patrata dhanam apnoti, dhana dharmam tatam sukham. That means when you have knowledge, you will be humble, which give you competence and wealth from which you can achieve goodness and blissness state in your life. So that is very important and applicable for most of the doctors who are practicing In this regard, I must appreciate the commitment and perseverance of Professor Agarwal in educating many students and clinicians through multiple webinars, which has given us knowledge and expertise in this field. Hematological disease in people of India, take example of sickle cell disease, is not the same as we see in the West. That means we have many things to do here only. It is not that everything will be extrapolated. We have many opportunities to do here. Day by day, there is improvement in resource funding, which can be availed by any trainee or any aspirant of hematology. For example, this year, my state Odisha's government has announced a special budget for medical research. It is to be given by recommendation of the head of the institution. These are good initiatives which is being followed, and we are privileged to get that one. Once you practice hematology in the community, don't forget that no patient should be deprived of treatment because of financial constraint and stay in the remote area. You should collaborate with government personnel, NGOs, community health professionals to give proper care to your patients. Always respect your teachers and mentors. I opted hematology after hearing a beautiful lecture on pediatric leukemia that was by Honorable Professor Mamen Chandi that pushed me to come into the field of hematology. I must thank my mentor, Professor Malay Ghosh, for whom I am here today. Lastly, I must request all the aspirants of hematology to take care of themselves so that they will live long and a healthy life so that they can give their best to the profession and the family. I conclude here. Let's update our knowledge on personalized treatment on multiple myeloma from Dr. Philip. Thank you, Dr. Khurana.
Thank you, Dr. Ashutosh, for that wonderful and very kind words. Will really help our future hematologist in their future career. Now, Dr. Philip Morio, the screen is yours.
Good morning. Can you hear me well?
Yes, sir. Please go ahead, sir.
Thank you. So thank you for this very kind invitation and this very kind introduction. So let's speak about the treatment of patients with newly diagnosed multiple myeloma. In Europe, in fact, we are following these EHA and ESMO guidelines, in fact, and we are treating patients according to eligibility for autologous stem cell transplantation, yes or no. And when patients are eligible for high-dose therapy, this is our favorite choice outside of clinical trials up to the age of 70 years. And we are considering that high-dose and frontline stem cell transplantation is the standard of care based on an important progression-free survival benefit. When you are comparing, in fact, the results of triplet combinations with or without autologous stem cell transplantation, you see that in blue, all studies phase 3 trials looking at triplet without or triplet in blue with autologous stem cell transplantation, across trials, we always have a PFS benefit with VRD plus autologous stem cell transplantation versus VRD alone, versus VCD high dose versus VCD VMP, and also when you are comparing KRD versus KRD plus autologous stem cell transplantation. So when the triplet are based on bortezomib with VRD or VCD, or when the triplet are based on carfilzomib as well, there is always a PFS benefit with the addition of high-dose melphalan and autologous stem cell transplantation. But the question now for induction before high-dose melphalan, the question is, should we use a triplet combination or should we use a quadruplet combination? And in fact, in Europe, currently, we are using as first option for induction either VRD, lenalidomide bortezomib index, or daratumumab plus VTD with thalidomide instead of lenalidomide. So should we use a triplet or should we use a quadruplet? In fact, we tested the prospective comparison of VTD, bortezomib thalidomide index, both before and after stem cell transplantation versus VTD plus daratumumab into the Cassiopeia study on more than 1,000 patients. And when you are looking at response and response rates over time, you see that each step of the strategy, we are increasing the response rate, the VGPR or better rates, or the CR rate as well. After induction, after stem cell transplantation, and after consolidation, and before maintenance. And in fact, those response rates are higher, significantly higher, when you are adding daratumumab to VTD. We looked also at minimal residual disease by flow cytometry with a threshold of 10 to the minus 5 for MRD negativity on the whole patient population, more than 1,000 patients. And indeed, before maintenance with dara-VTD and stem cell transplantation, the MRD negativity rate was 64% versus 44% only with the triplet combination VTD followed by stem cell transplantation. So there is a significant increase in the MRD negativity rate in the depth of response with a quadruplet versus a triplet. And this translated into a better progression-free survival. And see, at the time of the first report, the median PFS was not reached with dara-VTD versus 51 months with VTD alone. And the hazard ratio was 0.58, a significant benefit. And there was also a trend for a better overall survival with the quadruplet versus the triplet. So based on these results, dara-VTD was approved by FDA, by EMA, and approved in many countries as well. Importantly, when you are looking at MRD negativity before maintenance and immediately after consolidation, you see that the best outcome is observed among those patients who reached MRD negativity with the quadruplet combination, indicating that the depth of response is really important with the quadruplet. And you can also compare VTD MRD negative patients versus DARA VTD MRD negative patients. And the best group is definitely the one who did receive a quadruplet and reached MRD negativity. We looked also at sustained MRD negativity after 1 year or 2 years, in fact. And you see also that the best group for the outcome in terms of progression-free survival is the group of patients who reach MRD negativity during 1 year or sustained during 2 years with the quadruplet combination. And among this group at 2 years with dara-VTD MRD negative patients, very, very few patients did relapse, in fact. So the goal now of our strategy for young patients is to reach MRD negativity and, if possible, to have a sustained MRD negativity over time. What is interesting is that the earlier you are able to achieve MRD negativity, the better for your patients. We looked at MRD negativity before stem cell transplantation and after induction. And when you are MRD negative after induction, you can predict the outcome of your patients. And very early, for those patients reaching MRD negativity after induction with VTD and daratumumab, you see that with this landmark analysis by post-induction MRD status, you can predict that the progression-free survival will be definitely much better as compared with those patients who are not reaching MRD negativity after induction. So should we use a triplet VRD or should we use DARA VTD? That are the two options that are considered as the best ones, in fact, into the European EHA and ESMO guidelines. In fact, we will never have any head-to-head comparison of VRD versus VTD DARA. But we did a matched, adjusted, indirect comparison of Cassiope with VTD DARA versus other studies that looked at VRD or VCD, and we have matched patients according to initial characteristics. And there is definitely a better progression-free survival with VTD DARA versus VRD with a hazard ratio of 0.47, indicating that probably a quadruplet is better than a triplet. And importantly, this translated as well into an overall survival benefit in this matched adjusted indirect comparison when looking at VTD DARA versus VRD with a very strong hazard ratio in favor of the quadruplet. But should we use VRD with lenalidomide instead of thalidomide in order to reduce peripheral neuropathy versus VRD plus daratumumab? The Griffin study, a phase 2 trial run in the US, compared prospectively VRD before and after stem cell transplantation, followed by lenalidomide maintenance versus VRD plus daratumumab 4 cycles before and 2 cycles after stem cell transplantation, followed by len-dara maintenance. 200 patients were randomized, and with now a very long follow-up, there is also a progression-free survival benefit with VRD daratumumab, suggesting that definitely a quadruplet combination is better than a triplet for young patients eligible for autologous stem cell transplantation. And into this Griffin study, patients were enrolled up to the age of 70 years. But the true benefit of DARA VRD versus VRD was established very recently in this phase 3 Perseus study presented at ASH a few weeks ago. 709 patients were randomized to the triplet followed by len maintenance versus the quadruplet and high dose followed by len plus DARA maintenance. And the outcome in this phase 3 study that enrolled patients also up to the age of 70 years is in favor of the DARA VRD arm. And you see this fantastic PFS at 4 years of 84% with the quadruplet versus 67% with VRD alone. Those results are the best ever reported in a phase 3 study with a median follow-up of 4 years. So definitely the hazard ratio of 0.42 is showing a 58% reduction in the risk of death or progression in patients receiving DARA VRD. And this PFS benefit is observed across almost all subgroups of patients. With this short follow-up of 4 years, there is already a trend for a better overall survival. The OS data are not mature, but nevertheless, you see that very, very few patients died in the DARA VRD arm. And probably DARA VRD will be established as a new standard of care in the very near future. And currently, the authorities, FDA and EMA, are discussing of the approval of DARA VRD in the setting of autologous stem cell transplantation. We also have this study coming from Germany that looked at VRD versus VRD plus isatuximab. Isatuximab is the second-in-class CD38 monoclonal antibody. and our German colleagues did report of the first part of the study, the induction phase, comparing again a triplet versus a triplet plus a CD38 antibody. And they nicely showed that the MRD negativity rate assessed by next generation flow cytometry was also in favor of the quadruplet isatuximab VRD. 50% of the patients reach MRD negativity before autologous stem cell transplantation versus 35% with VRD alone. So triplet or quadruplet, I believe that if you have access to a quadruplet, if a quadruplet is reimbursed, definitely a quadruplet is the best induction regimen. And very often we are asking, well, should we change the induction regimen and switch to another regimen in case of suboptimal response? And in fact, when you are looking at phase 3 or phase 2 data with VTD DARA, with VRD DARA, or with VRD isatuximab, the response rate after induction is very, very high indeed, above 90%. So this issue of suboptimal response is not a big one, in fact, because almost all patients are going to respond to the quadruplet combination before high-dose therapy, and there is no need, in fact, to switch to another regimen to try to achieve a better response. And what about mortality? In fact, the mortality or the death rate after induction is definitely very, very, very low. That's 1% maximum. So a quadruplet combination is also highly feasible before stem cell transplantation. After high-dose therapy, we are proposing maintenance to all patients, and the standard of care for maintenance is lenalidomide until progression, based on this large meta-analysis of len versus placebo or len versus no lenalidomide on 1,200 patients, showing an overall survival benefit with len maintenance. But probably in the future, we are going to use 2 agents as maintenance. And there is this ongoing AURIGA study, a phase 3 trial, looking at post-autologous stem cell transplantation, the prospective comparison of len, the standard of care, versus len plus daratumumab during a long period of time. Into the Perseus study, len was proposed as maintenance after VRD, and len-dara maintenance was proposed after VRD daratumumab. But here, there is no second randomization with a true comparison of len versus len-daratumumab, and we will see if the authorities are going to approve as well len-dara maintenance during at least 2 years after the quadruplet combination and autologous stem cell transplantation. So the very pure study, in fact, to compare len versus len plus a CD38 antibody is the one coming from Germany, and we discussed the study design already. After high-dose therapy, patients are randomized to len versus len isatuximab, and we are probably going to hear about the first results of this German HD7 study at the next ASH meeting. So the landscape is changing, and probably we are going to switch to len, from len to len plus a CD38 antibody. But you know that we also have now new trials ongoing, looking, for example, at bispecific antibodies. And the MajesTEC-4 trial is looking at maintenance in a randomized fashion with either len, single agent, or teclistamab, single agent, or the combination of len plus tecli. So definitely future changes to come for maintenance, either with len plus a CD38 antibody or the introduction of bispecific antibodies targeting BCMA that are very effective agents as well. And this is also another study for maintenance looking at the prospective comparison of lenalidomide, single agent, versus elranatamab, the second-in-class bispecific antibody targeting BCMA. But we always have this subgroup of patients with high-risk cytogenetics, high-risk disease. That is a very difficult subgroup of patients to treat. So should we treat those patients with high-risk disease? 20% of the patients approximately. Should we treat them differently? The German group looked also at one specific phase 2 study for high-risk disease. And in arm A, transplant-eligible patients with high-risk disease were recruited and received a very aggressive quadruplet induction with carfilzomib, len and dex, KRD plus isatuximab, followed either by a single or a tandem stem cell transplantation, and consolidation with 4 drugs as well, KRD, isatuximab, and a very intense maintenance with carfil, len, and isatuximab. When you are looking at the results of induction and the best response to therapy, 60% of the patients in this phase 2 trial were able to reach MRD negativity. It means that when you have a patient with a high-risk disease, you can reach quite easily MRD negativity with a very aggressive quadruplet induction using carfilzomib. And after consolidation, 67% of the patients reached MRD negativity, and the paper was published less than 1 year ago. And also when you are looking at the outcome in terms of progression-free survival and overall survival, the results are very good, with more than 80% of the patients with high risk alive at 2 years. And definitely on the right-hand side, you see that patients reaching MRD negativity have the best outcome versus non-MRD negative patients. So the goal is to reach MRD negativity indeed with a very aggressive and long treatment. This is what we did as well in this phase 2 trial with the French group, and the paper was published a few weeks ago. We have recruited only patients with high-risk FISH, transplant eligible, and we treated them with a quadruplet induction with carfilzomib as well, plus daratumumab, KRD Dara, followed by a tandem stem cell transplantation approach. And consolidation was also proposed in the time in between the 2 high-dose therapy, followed by 2 years of maintenance with len and daratumumab. So a very aggressive treatment during 3 years for high-risk patients. And definitely, you see that the response rates are really good, in fact, with this very aggressive strategy, and MRD negativity rates assessed by next generation sequencing were indeed very, very high. 94% of the patients reached MRD negativity at the threshold of 10 to the minus 6. And this translated into a very good progression-free survival and a very good overall survival as well. 90% of the patients are alive after 13 months. So definitely for patients with high-risk disease in Europe, we are proposing a tandem stem cell transplantation outside clinical trials after a quadruplet induction. And this is one major difference when comparing standard risk disease and high risk. And high risk patients are treated with tandem high dose therapy. Important issues, in fact, for the future. Can we use MRD to adapt the strategy? And this is what we are doing in this ongoing MIDAS study with the French group. MIDAS for minimal residual disease adapted strategy. In fact, we are treating all patients that are transplant eligible with a quadruplet combination incorporating carfilzomib and a CD38 antibody. And after 6 cycles, we are looking at MRD negativity, yes or no, with next generation sequencing at the threshold of 10 to the minus 5. And when patients are reaching MRD negativity, what we are calling standard risk group, we are comparing no stem cell transplantation and a quadruplet combination alone versus high dose and a consolidation with the quadruplet followed by lenalidomide maintenance during 3 years. So here we are adapting the treatment, high dose versus no high dose, stem cell transplantation versus no stem cell transplantation, only for the group of patients with a very good response to induction and MRD negativity. On the opposite, for patients that are MRD positive, remaining MRD positive after induction, this high-risk group of patients, we are comparing a single versus tandem stem cell transplantation, arm C versus arm D, followed by a 2-drug maintenance strategy during 3 years. So here you see that maybe in the future, we are going to adapt the treatment according to MRD negativity after induction. That is a very strong predictor for PFS. And in the future, maybe we are not going to use any more stem cell transplantation because we have now this ongoing CARTITUDE-6 study that is prospectively comparing VRD-DARA, so a very good quadruplet induction, followed either by autologous stem cell transplantation or CAR T-cell therapy with cilta-cel that is targeting BCMA. So many changes for the future. And now what about elderly patients, those patients that are not eligible for autologous stem cell transplantation? In Europe, we are proposing as first option 3 different regimens: VRD, followed by Lendex, according to the SWOG study, VMP plus daratumumab, or lenalidomide, dex, and daratumumab, the DRD combination based on the MAIA study. But we know that not all elderly patients are the same, and some of them are fit and can receive a quite aggressive treatment, but others are frail, and we should be very cautious with the toxicity of our treatments. What is also very important to keep in mind that in the real life, for transplant ineligible patients, we have a very high attrition rate. The majority of the patients, elderly, are able to receive a frontline treatment, but when you want to treat them at the time of the first relapse, many patients are not able to tolerate a subsequent treatment because of comorbidities, renal impairment, infections, and so on. And the attrition rate in this real-life recent analysis from Dr. Fonseca is almost 40%. 40% of the patients are not able to receive a subsequent treatment at the time of the first relapse, and this is true for subsequent relapses as well. This is also the case in the very recent French analysis of real-life patients in France. In more than 1,000 patients transplant ineligible. All patients did receive a frontline treatment at the time of diagnosis, but you see that 30% of the patients were not able to receive a second-line treatment. So the attrition rate is 31%. So for elderly patients, you should give the best treatment upfront in order to have the longer progression-free survival. So what are we proposing? We are proposing VRD followed by Lendex according to the SWOG 777 study, a prospective comparison of VRD versus Lendex alone, published now 6 years ago in The Lancet. And VRD was associated at the time of the first report with a progression-free survival benefit of 1 year, 43 months versus 30 months with Lendex alone, and also an overall survival benefit of roughly 1 year, VRD versus Lendex, and this was statistically significant at that time. But when we have updated with a very, very long follow-up, the SWOG study, and looked at the subgroup of patients older than 65 years, there is only a trend for a better progression-free survival with VRD, and also only a trend for a better overall survival. And the median PFS with VRD, followed by Lendex, in patients older than 65 years is 33 months. But can we use VRD, bortezomib Lendex, in very, very elderly patients above the age of 75 years? In fact, we have this VRD light regimen that was proposed by the group of Boston. That's a phase 2 study. And you see that when we are adapting the dose of Len and the dose of bortezomib as well, this combination is feasible in very elderly patients. You can reduce the dose of Len from 25 to 15 milligrams. You can use bortezomib only weekly instead of twice weekly. And in this phase 2 study on a small number of patients, nevertheless, the progression-free survival is very good indeed, with a median PFS of 42 months. So we know now how to adapt the dose of each drug in order to reduce the toxicity and to have a long duration of treatment associated with a quite good progression-free survival. So the second choice in Europe after VRD is VMP plus daratumumab based on this Alcyone study, a prospective comparison of VMP versus VMP Dara. But in the VMP Dara arm, after 9 cycles, patients received also daratumumab maintenance until progression. So you are really understanding that there is really a difference in terms of treatment duration that is in favor of the Dara arm. The primary endpoint was progression-free survival, and there is definitely a PFS benefit with Dara VMP. The median PFS 37 months versus 19 with VMP alone, and this translated into an overall survival benefit. But the median PFS of Dara VMP is roughly the same as compared with VRD. And in Europe, in fact, Dara VRD is not widely used. And we are preferring, in fact, the DRD combination. And this is based on the Maya study, a phase 3 trial focusing on transplant ineligible patients. And you see that the ECOG at the time of inclusion was from 0 to 2, and the creatinine clearance cutoff value was 30 milliliter per minute. So we have here a study that did enroll patients with an ECOG of 2 with a renal impairment. So that's really close to the real life setting. And in the two arms, the treatment was proposed until progression. These are the patient's characteristics. More than 700 patients were randomized, and we have more than 40% of the patients that were older than 75 years of age. 44%, in fact, of the patient population. And when you are looking at the responses, in fact, at the time of the primary report and also later during the update analysis, the responses are really good. In fact, with DRD, more than 90% of response, including 50% of complete response, and the difference is statistically significant in favor of the triplet combination. And sorry, this translated into a better progression-free survival, and you see the median PFS with DRD, 62 months. So that's the longest progression-free survival ever reported, in fact, for transplant-ineligible patients, and the hazard ratio is 0.55. So that's a 45% reduction in the risk of death or progression with DRD. And the control arm, Lendex, is a very good one, in fact. The median PFS in the Lendex arm is 34 months. So there is really a huge benefit with the addition of daratumumab upfront. And there is also an overall survival benefit, and the median overall survival is not yet reached and will be probably roughly around 7 years for those elderly patients, knowing that the median age at diagnosis was 73 years, in fact. So DRD is a very, very active combination. And into the study, as I mentioned previously, 40% of the patients were frail. And what is the outcome of frail patients, in fact, treated with DRD? This is a sub-analysis of non-frail versus frail patients into the MAIA trial. And definitely, DRD is a better regimen as compared with Lendex alone for both subgroups of patients. The non-frail, that is benefiting most of DRD, but also the frail. When you are comparing in blue DRD frail versus Lendex frail, there is a big difference, in fact, with the addition of daratumumab. So that's why we are proposing this DRD regimen for all patients in Europe, and not only fit patients. Frail are able to tolerate the DRD regimen. And for patients above the age of 75 years, in fact, it was possible to reduce the dose of Len, use 15 milligrams instead of 25, and also the dose of dexamethasone was reduced from 40 to 20 milligrams weekly only. And this PFS benefit is also observed across all subgroups of patients, including patients with high-risk disease and poor cytogenetics with DRD. When you are looking at this subgroup analysis of MAIA for cytogenetic risk subgroups, patients with either 0 or only 1 high-risk cytogenetic abnormality, the outcome is very good indeed with DRD. But when we are looking at patients with 2 or more cytogenetic abnormalities, the median PFS is 36 months only with DRD, indicating that even with the addition of daratumumab, we cannot overcome, in fact, the poor prognosis of poor cytogenetics. An interesting sub-analysis is also the analysis of patients less than 70 years in MAIA, because we have this subgroup of patients from 65 to 70. And when you are analyzing the outcome of patients less than 70 years treated with DRD, you can see the very, very good outcome, in fact, in terms of PFS at 5 years, at 60 months. 67% of the patients did not relapse. And for overall survival, that's also true, because we have 80%, 79% of the patients that are alive at 5 years when they are less than 70 years. And we have here this gray zone, in fact, between 65 to 70, with a very, very good outcome with DRD alone. And in some centers in Europe, some colleagues are not using any more autologous stem cell transplantation in routine because they are considering that the results with DRD are so good that you don't need to use on top of DRD high-dose melphalan and autologous stem cell transplantation. So there is now a true debate to DRD from 65 to 70 or autologous stem cell transplantation frontline. And well, we are really discussing as soon as there is one comorbidity or you are thinking that your patient is not totally fit, you have a doubt for some toxicity between 65 to 70, many colleagues are not using stem cell transplantation anymore. That's what we are calling the gray zone here. And that's especially true because when you're looking at Perseus with VRD DARA and autologous stem cell transplantation and the very good results that we discussed previously, in fact, Perseus enrolled patients up to the age of 70 years. And into Perseus, if you are looking at the subgroup of patients between 65 to 70, you see that the hazard ratio, in fact, with VRD DARA is not, in fact, improved. The hazard ratio is 0.97, indicating that maybe we don't need to use DARA upfront in this subgroup of patients between 65 to 70. And we also know that for patients above the age of 65 years, we are awaiting for the results of VRD versus VRD plus isatuximab or VRD versus VRD plus daratumumab, the IMROSE trial with isatuximab and the Cepheus study with daratumumab. And IMROSE will be presented at ASCO and EHA in a few weeks from now. And we are going to see what is the outcome for elderly patients with a quadruplet combination without autologous stem cell transplantation. So we have those different options in this gray zone, 65 to 70, high dose, DRD, or a quadruplet combination with VRD and a CD38 antibody. And we know that IMROSE is positive. We have this press release from Sanofi and quadruplet combination. The study met its primary endpoint. And there is also this ongoing French study, and the results will be also presented at ASCO and EHA, that is currently comparing in transplant ineligible patients, non-frail, from 65 to 79, comparing Lendex isatuximab, so that's roughly the Maya schedule, versus VRD plus isatuximab. So we are here comparing the triplet versus the quadruplet in transplant ineligible patients. So many different options available for our patients. And well, to complicate the story, we know that CARTITUDE-5 is ongoing, and CARTITUDE-5 is currently comparing in transplant ineligible patients VRD followed by Lendex versus VRD followed by CAR T-cell therapy. So you see that the landscape is really changing very quickly as well. And other trials to come, how to improve DRD, the Maya regimen. There are here two studies that are ongoing, Frontline, DRD versus Len-Dara-Teclistamab or Len-Dara elranatamab. So the two bispecific antibodies targeting BCMA are currently tested in combination upfront in order to try to improve on the results of the Maya regimen. But as I mentioned previously, we have this patient population, non-frail versus frail, when patients are not eligible for transplantation. So we should probably adapt the treatment according to this frailty analysis. And we know that we have different tools, in fact, different scores that are available to assess frailty. The first one was developed on the left-hand side by the International Myeloma Working Group a long time ago, 10 years ago. But we also have another score coming from the UK, another one coming from Germany, the MyoRisk score, the Italian one, and the French one, the most recently published. You see that there are different factors that are tested and used in these scores, and performance status, in fact, ECOG, is well tested in almost all the scores, age as well, and we have different other factors across those proposals. This is the French score with an additive score looking at age, looking at ECOG 0, 1, or 2, and looking at Charlson. And this additive score is comparing, in fact, at the end of the day, two groups, frail with a sum of scores above 2, or non-frail patients with a sum of scores of either 0 or 1. And this is the outcome according to this frailty score. That is a very simple one, in fact, segregating patients into two categories. But there is this very provocative paper that was published recently from the group of Boston. They did a randomized study at the time of diagnosis for transplant-ineligible patients, and they did compare the physician experience, in fact, versus a systematic geriatric assessment at the time of diagnosis. And in fact, at the end of the day, the overall survival, the number of department visits, the number of days in the hospital, etc., is strictly the same, indicating that probably if you have a hematologist with a very good experience, maybe you don't need to use a frailty score. So this is very provocative for sure, but we should be, in fact, aware of this analysis. So this is one example, in fact, of what we are doing for frail patients. This French study, newly diagnosed patients above the age of 65, and all of them were frail according to our score. So we have proposed a randomization comparing len low-dose dex versus len daratumumab without dexamethasone. So the goal here is to see if we can have good results with daratumumab instead of low-dose dex, and we wanted to reduce the toxicity of the steroids. And those are very early results. We don't have data yet on progression-free survival, but you see that 300 patients were randomized. 60% of them were above the age of 80 years. 40% of them had an ECOG of 2, so all of them were frail. And in fact, the response rate at 8 months, 12 months is in favor of len daratumumab without dexamethasone. So we can achieve very good results, in fact, up to the, you see that this VGPR rate is above 71%, so that's very good results. And overall, 96% of the patients did respond to len dara versus 85% of response with len low-dose dex, and there is no increase in the toxicity when we are comparing, in fact, those two regimens. So this is what we are going to do probably in the future. We are going to find new combinations or new regimens that are easy to propose to patients and less toxic. And to close my talk, I would like to show you the very good data from this group in the Netherlands. they looked at frailty frontline in very elderly patients, but they made a dynamic assessment of frailty. And they are showing that many patients, in fact, and this is one example among more than 130 patients, at diagnosis, in fact, the frailty score was 3 for this very elderly patient. And when you are treating the patient, the frailty score is improving and is decreasing to 2. It means that sometimes at diagnosis, you have a lot of bone pain, and the patient is really tired because of the disease. But if you are treating adequately, your frailty score will improve. And they nicely show in this Hoven study that some patients that were frail after 3 cycles or 9 cycles became fit, in fact, at the end of the day. So we should not consider a frailty score only at the time of diagnosis, but we know that on treatment, the patients may improve. So I would like to thank you for your very kind attention today.
Thank you so much for that fantastic and lovely talk. It was really quite eye-opening for all of us, mainly the elderly myeloma part. That was fantastic. Thank you so much for your lecture, sir. And the house is open for the question answer discussion. And for that, I request all our discussants to please put the raising sign so that we can start our question answer session. Yes, Dr. Dinesh, your question, please.
Thank you very much for the informative lecture. Just wanted to, I think you briefly discussed this in your lecture regarding the tandem transplant in high-risk myeloma patient who are fit. So is it for all patients or how to select the patients?
No, we are proposing a tandem for all younger fit patients with high-risk disease, and we are not selecting anything else, in fact. But the definition of high risk is quite complicated, as you know, because if we are focusing only on the International Myeloma Working Group definition of high risk, we should propose a tandem in patients with 414 translocation, for example. And we know that not all 414 patients are the same. So what we need now is a consensus on the definition of high risk that is changing, you know, from one country to the other. So there is an ongoing effort with the International Myeloma Society to have a new definition of risk, of high risk, indeed. And that may help, in fact, for treatment selection in the future.
Okay, thank you so much.
Thank you, Dr. Dinesh. Dr. Tribikram Panda, your question.
Thank you, sir, for your excellent talk. So basically my questions are currently as far as the treatment of multiple myeloma is concerned, it is basically fitness adapted treatment and a partially maybe risk adapted treatment strategy. Currently, there is no uniform and comprehensive risk stratification criteria across different trials. So can you enlighten us whether this targeted NGS panel or circulating tumor cells and single cell transcriptomic analysis, all these can be incorporated into current existing risk stratification model as opposed to like currently conventionally we are using cytogenetics or FISH, so that we can properly, first of all, risk stratify a patient comprehensively and uniformly across different trials. Then we should maybe proceed to different modalities of treatment. So what is your
No, I fully agree with you. In fact, you know, that's what I was mentioning before. We have many different definitions, in fact, of high risk. Should we focus only on cytogenetics for 14, 16, and 17p? That was the, let's say, old official definition of poor cytogenetics. I'm not sure. And now we have genomics. We should incorporate probably chromosome 1 abnormalities as well, you know, and we are also looking at what we are calling ultra high risk, you know, with 2 or more cytogenetic abnormalities. We know that we also have beta-2-mic, you know, ISS3, that's beta-2-mic above 5.5. That is a very important prognostic factor and is remaining very, very important. Even in in studies published very recently, we have also patients with extramedullary disease at diagnosis. That's very few patients upfront, but nevertheless, 2 to 3%. So how we should define the high-risk disease? And you mentioned circulating tumor cells. That's also true, you know. So that's very difficult to implement all those abnormalities based on genomics, based on the tumor burden also. This is what we are going to publish very soon with the International Myeloma Society, because we would like to have homogeneous patient population, you know, based on risk, and to compare what are the different options according to this really real consensus definition.
Sir, currently, are you classifying 1p deletion as high risk in your routine clinical practice? 1p.
In fact, chromosome 1 abnormality should be associated with another one. I cannot tell you exactly what will be the future definition because we are still discussing, but the paper is currently circulating and will be published, I hope, before summer. So you will see that will be a very important consensus paper, I believe.
Okay, sir. Again, sir, the myeloma genomic project panel, they have given a abstract last time in us also, comprising a large cohort of patients, and they have seen that the targeted NGS level of around 228 genes. In that particular study, they have seen that around 40% of the patients, they were shifted from standard risk to high risk with this particular genomic mediated risk stratification. So, why we are not moving to a genomic targeted gene-based risk stratification in myeloma? Still, we are focusing on FISH and patients' performance status. So, what is your take on that, actually?
I didn't hear all your question because I'm sorry about this. Your voice was not very clear. But
Am I audible now?
we also have to consider, you know, not only some abnormalities on genomics, but also some cutoffs, you know. And for example, if you have only 5% of the tumor cells with the 17p deletion, for example, that's totally different from 50% of the tumor cells. So the cutoff are really important. That's not only the abnormality itself, you know. And for example, on 1q gain, we should consider 20% of the tumor cells at least, you know. So we also have to look at those thresholds. So please wait for a couple of weeks and you will have all these informations into this new paper that will be published soon.
Thank you so much, sir. Thank you. Thank you.
Thank you, Dr. Panda. Dr. Bhavani, your question, please.
Thank you, sir. Very informative talk. Sir, my question is, a middle-aged female presented with systemic disease and she received induction. Post-induction,
I'm sorry, I'm not hearing you, you know, I'm not understanding. There is a sort of echo for me.
Dr. Bhavani, please repeat the question
now,
once again.
So now I'm clear? Can you hear now?
Yes, please go ahead.
Sir, a middle-aged female presented with a fracture, pathological fracture. She received induction. Post-induction, her MRD was negative by flu. And PET-CT showed only residual disease at the region of the fracture. Sir, is there any role of radiotherapy, local radiotherapy to that region?
I'm sorry, doctor, I'm not
Bhavani,
hearing you, you
was
know.
not clear. Can you please repeat once again, or you can type your question?
Sure.
Sir,
Just
am I
repeat
audible now?
Yes, you are audible. Now you're audible. Please go ahead.
Sir, a middle-aged female presented with a pathological fracture and she received induction. Post-induction, her MRD was negative by flow, which is 10 power minus 4. And in the PET-CT, it is showing mild residual disease at the pathological fracture. Is there any role of local radiotherapy?
No, that's a very good question, you know, because we are considering that a good response is based on MRD, for example, MRD only. But we did some studies looking at MRD within the bone marrow plus PET-CT, and the PET was remaining abnormal in some patients with true MRD negativity within the bone marrow, even at 10 to the minus 5. So
Yes, sir.
to be really in CR, you need to be, to my opinion, MRD negative within the bone marrow, even by flow or NGS, but also with PET-CT. And for those patients that are still PET positive, you may use local radiotherapy. And this is what Bart Barloghi, this concept was developed by him more than 10 years ago or 15 years ago. So you are perfectly true. Yes, there is a role of local radiotherapy when you still have imaging positivity after a very good treatment induction. Yeah.
Sir, post LCT also, is it true we can give radiotherapy to that local region if it is persistent?
Yes, yes, yes.
Okay, thank you.
Thank
Thank
you,
you so
Dr.
much.
Thank you, Dr. Bhavan. Dr. Meena, your question, please. Yeah.
Thank you, sir, for your informative talk. My question is, sir, as you mentioned, in case of transplant individual patients, you are preferring the DRD versus or DR. In these patients, are you considering the MRD testing, and how frequently you are doing this MRD testing?
Oh, that's a very good question. We are not doing MRD assessment outside of clinical studies in routine because this test is not reimbursed in my country. We are only doing MRD inside clinical studies. But that's true that into the Maya study with DRD, 30% of the patients, 30, did achieve MRD negativity. So that's not the majority of them. But when you're looking at patients MRD negative with DRD versus patients MRD positive with DRD, there is a big difference in terms of PFS, suggesting that, yes, definitely MRD negativity is also very important for transplant ineligible treated with DRD. So we are assessing MRD. We were assessing into the Maya study MRD negativity as soon as patients were reaching VGPR. And this is potentially something that you can do. As soon as your patient is reaching VGPR, you can look at MRD negativity. And if MRD is negative, definitely the outcome will be much better. And then there is also this concept of sustained MRD negativity with in transplant ineligible patients, and into Maya, sustained MRD negativity 1 year apart was associated also with a better outcome. So if you want to assess frequently MRD negativity, you need to assess at least 1 year apart.
Okay, sir. Thank you, sir. Thank you so much.
Thank you. So we have some couple of questions from the audience. Dr. Arun wants to know, for transplant ineligible newly diagnosed multiple myeloma patients with high risk cytogenetics, DRD versus KRD or DARA KRD, what would be the way to go?
Well, in fact, when you're looking across trials for all combinations, the subgroup of patients with post-cytogenetics, the outcome is worse. This is true for VRD, standard risk versus high risk. There is a difference. This is true with DRD into the Maya study. If the patient is able to tolerate a quadruplet combination with VRD and a CD38 antibody, and you have access to this quadruplet, I will go for a quadruplet in transplant ineligible patients.
Thank you, sir. Another question from Dr. V. Arun. What criteria is being used to assess the transplant ineligibility in your current practice?
This is the most important question because we don't have any consensus on the definition of transplant eligibility. That's really the fitness. You know, age is not per se the most important criteria. In Europe, we are saying, okay, up to the age of 70 years. But we know that it's 66, 68, you can have patients that are becoming frail because of comorbidities. So you should take into account age for sure, but also comorbidities and cardiac ones for sure, obviously, and performance status, ECOG as well. You know, so we are the cutoff for us for transplant eligibility is 70. Above the age of 70 years, in my country, we are never proposing stem cell transplantation. And then there is this gray zone, as I mentioned, 65, 70. And as soon as the patients are not perfectly fit, we are switching to DRD and probably in the future to a quadruplet without stem cell transplantation.
Thank you, sir. So if transplant eligibility at baseline decides a line of therapy, some patient whose performance status improves during therapy, will not they be excluded from benefits of stem cell transplant?
Well, in fact, this is what we are doing very often. You know, we are starting the induction, and according to the improvement, you know, in performance status and in renal function and so on, we are starting first with VRD DARA, for example, and then if the patient is improving, we can harvest stem cells and go to stem cell transplantation. And if we are believing that after 4 cycles of a quadruplet, the patient is not improving in terms of performance status, we are not proposing stem cell transplantation. So we have to adapt, you know, the dose for sure, and the treatment according to the improvement of performance status over time.
Thank you, sir. Another question from Dr. V.A. Arun. Do you think there is any patient of myeloma who should not be given anti-CD38 monoclonal antibody upfront?
In fact, indeed, that's a very good question. But when you are looking at transplant eligible patients, CD38 combination definitely as induction, that's better than no CD38 antibody. And when you are looking also at transplant ineligible patients, as soon as we are adding a CD38 antibody, we are having some benefits in some of PFS. Lendex versus Lendex DARA, now VRD versus VRD isatuximab. So definitely, if possible, at the end of the day, all patients are going to receive a CD38 antibody upfront if the access is good and if reimbursed, obviously.
Thank you, sir. Another question from Dr. Lily. Daratumumab is very costly. Can you comment if the lower dose, lower than 16 mg per kg or shorter duration of treatment can be beneficial as well?
Yes, definitely that's a a very good question. I believe that regarding the dose, what is defined, what is used, in fact, is the optimal dose, because we looked at different doses. So reducing the dose is not adding anything. The issue is the duration of treatment. And for sure, with DRD, for example, we are supposed to use DRD until progression and DARA until progression. And that's probably not necessary. So, but we don't have a lot of data, you know, so we need to build academic studies with fixed duration of daratumumab. And probably we don't need 5-6 years of treatment. So when you are looking also at the dose intensity, you see that some patients had to stop daratumumab before because of infection and so on. And probably after 3 years into Maya, you could stop the treatment without any other, without any different outcome. But we should work on this. Definitely, that's a very, very important question. And we have very few data indeed.
Thank you, sir. Another question from Dr. Sumit Mirk. Subcutaneous DARA fixed dose versus IV DARA. What is the difference in the pharmacokinetics?
There are, in fact, at the end of the day, there are some difference in terms of pharmacokinetics, obviously because of the peak, etc. But what is important is not only to look at the Cmax, you know, is to look at the overall data, and the fixed dose is perfectly fine, you know, and is really covering. We have the same PD analysis at the end of the day. So I believe that all of us now in Europe are using the sub-Q with a fixed dose. The issue is for patients above the weight of 100 kilos or less than 40 kilos, maybe we could ask if we have exactly the optimal dose with a fixed one sub-Q, but that's for very few patients indeed.
Thank you, sir.
There is another question, in fact, in the chat regarding the maintenance for high-risk disease, and that's a very good question, because currently we can use LEN, the standard of care maintenance for high risk, but many of us are using already 2 drugs for high-risk disease. We have some data of the combination of len plus bortezomib, and probably len-bortezomib is better than len. And we also are using more and more CD38 antibodies in combination with len for patients with high-risk disease, 2 agents instead of 1, in fact. But what is the optimal duration? That's really a question mark, you know. We are proposing with the French group 3 years of maintenance, because probably that's the best in terms of efficacy versus toxicity. Even with lenalidomide single agent, many patients have to stop because of GI toxicity, infection after 3 years. So that's why we are proposing into our guidelines 3 years of treatment.
Thank you, sir, for clarifying that maintenance part. Question from Dr. Sumit Mid. In a patient who is transplant ineligible patient, if you give DARA-RD, DRD, of 1 to 2 cycle, and patients becomes transplant eligible after 1 to 2 cycles, can we go for DARA-PRD before stem cell transplant?
Yes, this is something that you can do. Yeah.
Thank you, sir. And the same question from Dr. Sumit Meg. Do you repeat a fish every time a patient relapses?
Yes.
A
Yes.
patient.
Because we know that we can have clonal evolution, you know, and especially if the patient is not presenting with 17p at the time of the progression, we know that we can have a clonal evolution. If you have 17p at the time of diagnosis, you don't need to repeat, you know. But if you don't have a diagnosis, that's very interesting, you know, to have this important information, because you should intensify the treatment in case of clonal evolution with a more aggressive clone. Yeah.
Thank you, sir. One of his patients had 11-14 at baseline and relapsed 4 years after VRD, stem cell transplant, and len maintenance. Repeat fish at relapse shows 1Q gain without 11-14. Is this patient eligible for venetoclax-based treatment now?
Well, usually when you have 11-14, you always have 11-14 at the time of the relapse. This is something that is not disappearing, you know. Even if you have other clones, subclones emerging, they can acquire new abnormalities, but 11-14 is very stable, you know, that's a very early abnormality. So, well, we can use venetoclax in patients with 11-14, but not without 11-14. I will not use venetoclax for patients without 11-14.
True, sir. Another question from Sumit Merik. Do you look at clone size of 17p deletion on baseline fish, and what is the significance of that clone size?
So the clone size is very important because, as you know, into some studies, patients were considered to have a 17p, even if they only have 1% of the tumor cells harboring this abnormality. And this is probably not true, you know. There is really the cutoff when you are comparing different series. The cutoff for a more aggressive disease should vary from 20% to 50%. If you have at least 20%, you have a very aggressive clone and disease with 17p. If you have less than 20%, probably you should not treat your patient differently.
Thank you, sir. Another question from Dr. Jyoti Sauni. What are the minimum cytogenetic studies do you recommend for every newly diagnosed multiple myeloma patients?
Well, I believe that if you are following the International Myeloma Working Group definition of high risk, that's 17p, 414, and 1416. But we know now that we have also chromosome 1 abnormalities. We know that's important to have the information of 11-14, yes or no, on top of this, because you have a sort of targeted treatment with venetoclax, although venetoclax is not officially approved because we have 2 negative studies with venetoclax, the Bellini study and recently the Canova study that did compare Pomdex versus venetoclax dex in 11-14 patients. Well, but this is something that we are doing. We are systematically looking at 414, 17p, 1416, chromosome 1 abnormalities, and 11-14.
Thank you, sir. Another question from Dr. Sumit Mill. Does plasmablastic morphology of plasma cells have any prognostic relevance today in the era of FISH and MRD after treatment?
Yeah, that's definitely, that's a more aggressive disease. That's another, so that's why when we are discussing about high risk, that's not only high risk fish. We know that the tumor burden is important, the morphology, plasmablastic, or circulating tumor cells, or CNS involvement, or extramedullary disease. So we have plenty of factors, so, and we should consider all of them, yes.
So on the same note, does DARA really work in extramedullary myeloma? And what is the current treatment approach for extramedullary myeloma?
Ooh, that's very complicated story. As I mentioned, at diagnosis, we have very few patients with EMD, in fact. That's less than 5% and probably less than 3%. EMD, that's uh, frequently observed for very advanced patients, after multiple relapses. And for those patients, the situation is very, very difficult, even with CAR T-cell therapy, even with bispecific antibodies, it's remaining a very difficult subgroup of patients to treat. And some of us are using, let's say, old chemotherapies, such as VDT-PACE, for example, but you can also use local radiotherapy, so on top of combination treatments. So I don't have any recipe that is very, very active, for those patients, unfortunately.
Thank you, sir. Dr. Sumit Milk has another question. A high-risk abnormality like translocation 1416 with multiple trisomies. How do you classify this as high risk or standard risk?
High risk, yes. Well, according to the Mayo Clinic, group and Shaji Kumar, well, there are controversies, regarding 1416. The French group published that it was not high risk. The Mayo Clinic published that it was high risk, whatever the other abnormalities that were observed. So there is here a controversy, but the number of patients is very, very small. That's 2% of the patients. So that's not a big issue, to my opinion.
Thank you, sir. Another question from Dr. Meena. What infection prophylaxis would you give for prolonged DARA exposure?
We are using valacyclovir and cotrimoxazole. We are not proposing any antibacterial prophylaxis, and we are never proposing systematically IVIG, for example. So that's cotrimoxazole and valacyclovir.
Thank you, sir. Another question from Dr. Shivam. How would you treat your patient in 2024 for primary plasma cell leukemia?
Yeah, that's a very difficult question. We were until recently proposing systematically tandem stem cell transplantation as well. And I believe that we should propose a quadruplet combination. We published some papers, phase 2 data with VAD or VRD, alternating cycles of different combinations. But now we are moving to quadruplet and tandem stem cell transplantation, very similarly to what we are proposing for high-risk disease. But for plasma cell leukemia, we are also systematically looking at 11-14 translocation, because half of the patients with plasma cell leukemia are presenting with 11-14 translocation. So venetoclax can be useful at the time of the relapse for those patients if they have 11-14 in 50% of the cases.
Thank you, sir. Dr. V.A. Arun has asked a question that indications of allo stem cell transplant in any myeloma patient outside the clinical trial.
Not in our country anymore. Allo is not proposed into our guidelines because, well, we are quite fortunate to have access to new combinations, quadruplet, and also to have access now to CAR-T and bispecific. We are not doing allo anymore, in fact.
Another question from Dr. Sumit Milk. If you are going quadruplet therapy, DARA, VRD, any problem with stem cell collection with DARA? When we are going
Yes,
quadruplet
in fact, that's true. That's true that with quadruplet combination, the stem cell harvest is less as compared with a triplet. In our recent studies with VTD DARA, VRD DARA, the median number of CD34 positive stem cells were roughly 5 million. But we have some stem cell harvest failures, So we are now systematically proposing plerixafor in order to have an adequate graft for those patients. That's true. That can be an issue. So you don't need to wait a long time. and to wait after 4, 5, or 6 cycles of a quadruplet. You should harvest the stem cells after 3 cycles, immediately when you have a very good response.
Thank you, sir. Another similar question from Dr. Digampan Panchal. If a patient shows translocation 11-14 upfront, would you start with venetoclax upfront?
No, never. Venetoclax, that's only in the relapse setting. 11, 14 are considered the standard risk patients, so you don't need to use, well, and we don't have a lot of data, with venetoclax upfront. No, that's only for relapse patients.
And if the patient has been given a relapsed patient, then what is the dose and what is the duration?
Well, you know that we tested and we published different doses of venetoclax. We published from 200 to 800. It should be at least 200, and probably 800 milligrams is too much of venetoclax. In my practice, I'm using 400 milligrams. And if possible, if the patient is not refractory to daratumumab, you can combine venetoclax with dara, and you can also combine venetoclax with bortezomib. And Dr. Nizar Balis, for example, published very, very good data on venetoclax, bortezomib, and daratumumab for 11, 14 in the relapse setting.
Thank you, sir. Sir, question from Dr. Devasya. You have not mentioned anywhere about pomalidomide. So when would be the pomalidomide the drug to be incorporated in myeloma?
Well, pomalidomide is a very good agent, definitely. And we know that some patients can be rescued with POM when they are LEN refractory. We are not proposing POM upfront because we don't have any data. POM is a very good agent in the relapse setting in combination with potassium inhibitors, Carfil POM-dex, for example, a KPD regimen, or POM-VD, POM bortezomib dex. We can also combine POM with daratumumab, the PD-DARA or PD-isatuximab based on the ICARIA study or the Apollo study. So we are using POM a lot, but in the relapse setting only and never frontline.
Thank you, sir. Question from Dr. Weir. There are few studies that if you're using DARA in induction as well as in consolidation before a transplant, can we skip DARA in maintenance? Because if the patient has been added, wonderfully done with DARA in induction or consolidation, can we skip in maintenance?
Yeah, well, that's a very good question. You know that into the Cassiope study, we looked at DARA upfront for all patients, and then patients were randomized to DARA maintenance versus no maintenance. And the benefit was not obvious as maintenance when patients did receive DARA upfront. But now with a very, very long follow-up, the data are in favor of DARA maintenance. And we are going to show this, to propose this during the next EHA meeting. We will show the long-term follow-up of Cassiope. So I believe that's probably you need to have not only DARA upfront, but also DARA in maintenance, but not single agent, in combination with LEN, most likely.
Thank you, sir. Another question from Dr. Shilpa. Light chain myeloma patient developed irreversible chronic kidney disease.
Yeah.
Treatment of choice during induction, and what is the role of maintenance DARA in this scenario?
Well, that's a very good question. Well, for us, the best treatment upfront that we can use is probably VCD and daratumumab. Cyborg-D VCD is a very good regimen, and we know that, for example, for patients with amyloidosis, like in the Andromeda study, VCD DARA was widely used. Now, the role of DARA maintenance, we don't know. We don't have any data for this group of patients. So you should try to propose the best treatment up front in order to try to reverse, from renal failure to rescue the renal function. So we are using VCD DARA in this setting.
Thank you, sir. And the last question from Dr. Sumit Merrick. Any head-to-head comparison between PI plus IMiD versus PI alone in the maintenance treatment in high-risk myeloma?
We have some data coming from Spain, and the Spanish group compared LEN versus LEN plus ixazomib. And the study, unfortunately, was negative, So that was disappointing because we thought that with the addition of ixazomib, that is an oral agent, we could have some benefit. Unfortunately, the study was negative. So that's an issue.
So if we can use only bortezomib in high-risk myeloma versus bortezomib plus len, does this any benefit, any advantage of adding bortezomib plus?
We don't have this prospective comparison of bortezomib single agent versus bortezomib and len, but in my practice, I would like to use the two drugs for high-risk disease as maintenance, and this is what I'm doing currently. Yeah.
Thank you, sir. Dr. Ashutosh, your question, please. Dr. Ashutosh?
Am I audible?
Yes, you're audible. Please go ahead.
Sir, thank you, sir, for your lucid presentation. I have few patients who are recurrent genetic abnormalities in addition to multiple myeloma. Like I have a patient on baseline had monosomy 7, monosomy 5. Then I have one patient of 922 translocation in addition to multiple myeloma, and that is persisting in remission also. After 4 cycles, when we are repeating the bone marrow, it is persisting. But patient is not symptomatic because of any myelodysplasia, cytopenias, or high TLC count. Sir, how to address this type of issues?
Well, if the patient is totally asymptomatic for another disease, I will not do anything else, with careful wait and watch assessment.
Okay, sir. Thank you. Thank you, sir.
Thank you.
Thank you, Dr. Ashutosh. Dr. Yimon, your question, please.
Sir, thank you. May I know your experience in diagnosing non-secretory myeloma?
For non-secretory multiple myeloma,
Yes,
I'm
you are approved.
treating them the same as standard risk disease.
Yes. Sometimes we have the plasma cell, fine-grade plasma cell in bone marrow, and there no evidence of clonality. So how will you proceed?
In case of,
Like
sorry,
that case.
Can you
We have a case like the bone marrow in binding to a plasma cells and many plasma cells, but there no evidence of clonality in IFE or SPE. So how will you approach like that case?
well, there are some situations for whom you don't have any clonal abnormalities. I'm not treating those patients as multiple myeloma. You need to have clonality by definition.
Yes. Yes. Second question is, how do you adjust lenalidomide maintenance dose in the occurrence of cytopenia without evidence of disease progression? Yes.
Well, in fact, you're reducing the dose, well, the usual dose for maintenance is either 10 or 15 milligrams, continuously, or 21 out of 28 days. So first of all, you should reduce the dose, and you can go, well, the lower dose, as you know, is 5 milligrams, and the lowest dose is 5 milligrams every other day. And add GCSF, for example. And if you still have neutropenia and risk of infection, you should stop the treatment.
Yes. Thank you.
Thank you.
Thank you, Dr. Yimon. So I finished all the questions from the chat box. Any
Thank
discussion to ask any other question to Dr. Philip? Okay. So
Well, Dr. Perwal here.
Yeah.
I just want to thank you, sir, on behalf of Mumbai Hematology Group. A very long QA session, and you very patiently answered everything. Extremely grateful to you.
Thank you so much. It's good to see you.
Right,
Bye.
sir.
Take care. Take
Bye,
care.
sir.
Thank you, sir. Thanks a lot, sir, for that wonderful question answer session, and what a wonderful lecture. Thank you so much.
Thank you.
Thanks a lot.
Thank you. Bye-bye.
Yeah. And thank you.